Yes.
Okay, you are. Great. Good morning, everyone. Thanks for joining. We'll give it a couple more minutes before we get started and allow some more people to trickle in. And allow some more people to trickle in. Good morning, everyone. Thanks for joining us for the third of our Q&A sessions for Central Health's 2020 Demographic Report. My name is Ivan Davila, and I'm the Director of Communications and Community Engagement at Central Health. I want to recognize our President and CEO, who's joining us as well, Mr. Mike Geeson. Thanks for joining. And as people continue to trickle in, we're going to go ahead and get started because we do only have 30 minutes for this Q&A session. And so again, my name is Ivan Davila. I'm the Director of Communications and Community Engagement. If you missed our first two sessions on poverty and population trends and enrollment and utilization, you can find the recordings on our YouTube channel, which I'm about to post a link for on in the chat box, so you can find it there. You can also just search Central Health in YouTube. All right, so in terms of our virtual house rules, we are live streaming this session on Facebook. For those of you who RSVP'd and were able to join us via Ring Central, either by video or by phone, you will be muted until about 11:40 when we open it up for questions. If you're joining us by video, please feel free to drop your questions in the chat box and we will answer them as we go, or during the Q&A time allotted. If you're joining us by phone, please hold your questions until we open it up for questions. To unmute your line, you will need to press *6. Again, those of you joining us by phone, you'll need to unmute your line by pressing *6 during the Q&A session, during the Q&A time allotted. In the spirit of inclusivity and to ensure the efficiency of the meeting, we strongly encourage our attendees to ask one question or make one comment at a time. If we don't get to your question, we will have our experts address them and send those to all participants in a follow-up email if you register to attend and we have your email address. We will use the mute button throughout the meeting and during the Q&A time allotted to ensure only one person is speaking at a time. During the Q&A time allotted, we ask that you raise your hand if you have a question and we will unmute your line. For those of you joining via Facebook, we will do our best to address your questions in a timely fashion. Thanks again for joining, everyone. Now we're gonna go ahead and get started. And we always talk about Central Health initially, in case there are people joining us who don't yet know who Central Health is or what we do. Central Health is a local healthcare district that ensures Travis County residents with low income can get quality healthcare. We are primarily funded by property taxes, and we were created in 2004 by Travis County voters. We are a separate political subdivision of the state of Texas. We rely heavily on demographic and clinical data as well as public input to ensure our strategic priorities and budget align with the healthcare needs of our community. And one of the tools that we use to collect and report data to guide our work is the demographic report, which we're here to talk about. Today, we will be discussing chronic conditions examined in the demographic report. And now I'd like to introduce our speakers today. Here joining us are Sarita Clark-Leach, who is the Director of Analytics and Reporting, and also JP Eichmiller, who is our Senior Director of Strategy and Information Design. With that, I'm going to go ahead and turn it over to them. Sarita?
Hello, everyone, and thank you. As Yvonne noted, this will be the third in our series of community conversations about the Central Health's 2020 demographic report. We previously discussed population and poverty trends, access, enrollees, and utilization trends, and today we'll be talking about chronic burden trends. So let's start off by defining a chronic disease or chronic condition. CDC defines it as a condition that lasts for a year or more, requires ongoing medical attention, and or limits daily activity. The examples of chronic disease include heart disease, cancer, diabetes. And these chronic illnesses are leading causes of death and disability in the United States, and they also are leading drivers for about $3.5 million in annual national healthcare costs. For our study, we decided to look at 8 conditions. They include asthma, COPD, diabetes, heart failure, hypertension, malignant neoplasms, also cancer, renal failure, and behavioral health. These are some of the most common and preventable health conditions in Travis County, and they also account for some of the leading causes of death in the county. You'll note in the demographic report that prevalence is presented 2 different ways. We show the total number of individuals diagnosed with a chronic condition, and that gives insight into the total disease burden in a given population, and it helps to inform things like capacity need for specific location. And then you have prevalence rate. And the prevalence rate is a proportion of people diagnosed in a given population with a chronic illness. And that helps us to understand whether a population is disproportionately impacted with chronic conditions relative to the risk of that condition. We'll move into some noted trends by focus area. But before that, let's contextualize. So we'll start this trends discussion off by putting everything into context. We must keep in mind that while individual behaviors, public health functions, and quality clinical interventions play important roles in the prevention and management of chronic diseases, other social and environmental factors are also impactful. While this study honed in on some of those factors that play a part in disease prevalence, including age, race and ethnicity, socioeconomic status, and access to healthcare, other social and environmental factors can have significant impact. Those factors can include, but certainly aren't limited to, political environment. For example, a study by the Urban Institute published in 2017 found that states with larger African American populations, all else being equal, have less generous and more restrictive state temporary assistant relief for needy families. So that's TAMP, and some of you may be familiar with that program. Such policies can lead to a rise in malnutrition in the affected population, which, again, malnutrition is a risk for chronic illness. Another example are immigration policies that stir up fear of deportation and uncertainty in the population that results in increased chronic stress. And of course, chronic stress, as most of us know, is a strong risk, is a risk factor for multiple chronic diseases. And if you think about things like environmental pollution, polluted land, water, air are directly linked to a host of chronic illnesses, including but not limited to cancer, respiratory, cardiovascular diseases. Think about housing near trucking routes or congested highways. A person's work environment, as it potentially contributes to chronic stress or fluctuate or functions as a barrier to care if employees are unable to schedule medical appointments during work hours? Or are their job sites safe? Um, Conditions of low-income housing. Are the buildings in which our patients live being well maintained? Are they sick buildings with moldering ventilation or vermin infestation that can be a contributor to or exacerbate asthma or other respiratory illnesses? Access to nutritious food. We often hear the term food desert when we think about lack of access to nutritious food. However, we have to keep in mind that proximity to nutritious food is half the battle when it's nearby, but one can't afford to pay for it. Safety. Does the population feel safe in their communities? Are the streets well lit at night? Do they have continuous and evenly paved sidewalks that would allow for fitness activities? Are there safe parks for people to gather and partake in physical activity? Are residents in the community disproportionately at risk of experiencing a violent crime, which not only creates chronic stress, but can also limit the community's ability to gather? Transportation resources. We should keep in mind that transportation barriers are not just limited to how close a resource is to the community. You can have a clinic that's only 3 miles away that requires a half-a-mile walk to the closest bus stop, and with transfers in between that require more walking. So think about what that might mean for someone who is medically complex. As you can tell, these factors that influence chronic prevalence can be interdependent and inextricably layered, which brings us to the emergence of the syndemic model that epidemiologists and other researchers are using to understand how multiple factors may contribute to diseases. Rather than looking at each factor independently, it's about understanding their multiple layers having an impact on health, starting from the outside in. Political, economic, and environmental conditions influence social determinants of health, and so on. So what? How can an organization that's charged with improving access to care use this knowledge? And I'll read from a quote directly from the Lancet, who is currently using the Syndemic Model. Although there may be little that clinical practitioners and public health interventionists can do about the presence of social and political circumstances that might negatively affect the health, the syndemic framework allows for the potential to mitigate those effects by appreciating the complex nature of certain diseases and conditions, and for addressing the array of factors that give rise to them. In the pursuit of practicing more socially conscious medicine, Syndemic suggests that context is key. So now let's look at some findings from our report. First, we'll look at similar populations with disparate outcomes when it comes to prevalence. You'll note that the residents of Colony Park and Del Valley are more or less similar in average age and ethnicity, and utilization enrollments as well. But why does one area have higher prevalence of chronic conditions compared to the other? The answer to that question will require a closer look at the populations. That can include assessing health literacy in the community, access to nutritious food, neighborhood safety, availability of recreational spaces. And it may also require risk stratification of the population in which you hone in to really understand who in that population is being affected specifically. Now we'll look at areas with dissimilar populations with similar outcomes. You'll note that East Central Austin has a higher concentration of people at or below 200% FPL, about 3 times the concentration compared to Leander Lago Vista. You'll also note that Leander Lago Vista has a larger older population. While there's a large proportion of Black residents in East Central Austin, the Black population in Leander Lago Vista is negligible. So, given the different population characteristics, why do both areas have the highest prevalence rate in the county for many of the chronic conditions examined for our central health population. Again, we'd have to take a closer look at some of the other factors at play, but one might assume that it could be a function of the high prevalence could be due to the fact that Leander Lago Vista has an older population. And we know that age is a risk for chronic diseases, including cancer and COPD. It's a little more difficult to hypothesize what's causing high chronic disease prevalence rates in East Central Austin. The population is similar racially and ethnically to other focus areas. It doesn't have the highest proportion of households at or below 200% federal poverty income level. Food access come into play. Are there recreational spaces available to people who live there? Again, we would have to do a drill down into the data to identify factors contributing to the poor outcomes for that population. A couple of more observations. Pflugerville has a lower concentration of households in poverty when compared to other focus areas. They also have the most diverse population in terms of race and ethnicity. This population has a slightly larger proportion of older folks, with a good proportion of Black and Asian residents. One might hypothesize that it's not surprising to see high prevalence in this population of heart failure, given that older folks and Black and Southeast Asians are at a higher risk of heart failure than other groups. Looking at Southeast Austin, it's interesting to note that higher cancer rate in the relatively younger population. Again, could that be attributed to the number of inactive landfills in the area? More research would have to be required, is required to understand why. And finally, you'll find this heat map that shows that chronic conditions ranked by prevalence rate for each focus area. The darker the boxes means the higher the prevalence rate. And here we've highlighted again East Central Austin and Leander Lago Vista. So what are the key takeaways? Remember that context is key. One must consider how inequities in the condition in which people live, work, grow, and age foster and perpetuate a higher disease burden in some communities compared to others. A deeper dive into the data will be necessary to plan care for these chronically ill populations relative to their geography. Thank you.
Sarita, thank you so much. That was a lot of information and thank you so much for putting it into a format that we could understand. As you mentioned earlier, before we open it up to questions, I just have one question. As you mentioned earlier, there are multiple layered factors determining an individual's health, especially when it comes to chronic conditions. You know, you mentioned transportation, you mentioned the infrastructure around and access to healthy foods. How does Central Health handle complex cases for its MAP population? I know we have a medical management program, but can you just help us understand how Central Health manages
Sure.
complex cases, people with chronic conditions and multiple chronic conditions?
Sure. As you mentioned, Central Health has a medical management team that has care teams with nurses, social workers, community health workers, and liaisons for the community. And they get to know our more medically complex patients or our socially complex patients in a way to understand and sort of meet them where they are. You know, they understand what the barriers are to care or to help for that population, and they work to fill in those gaps, whether it's connecting them to resources in the community or, you know, making sure that they're following up on their appointments. These folks will actually help assist folks to their appointments or attend appointments with them. So getting really familiar with the patients and their care and what they need is certainly one way that the community is being served and these patients are being served.
Thank you, Sarita. And I understand that we are adding 5 community health workers to this team this fiscal year, which is amazing for our MAP members. Are there chronic conditions?
Add,
Go ahead. Yes.
I'm sorry. I should add too that all of these folks on these teams are trained to meet folks where they are, to understand where they're coming from culturally, so that they can care for them appropriately.
Super important. Thank you for that. Are there chronic conditions that Central Health prioritizes over others? Which are the most common in the community? Yeah.
Sure. So the most common chronic conditions in our community are diabetes and hypertension, and both of those contributors to those more severe, complex chronic illnesses such as heart failure, end-stage renal disease, or just kidney disease. And how we prioritize, really, it's, we've worked on projects to ensure that our populations, our patients, are getting screened for cancer regularly, whether it be breast, cervical, colorectal. We partner with our Dell Medical School, Ascension, and different organizations, again, to ensure that our population has the right specialty care available to them. And we have worked in the space where we've done, work around our heart failure population, our cancer oncology population, our kidney disease population. So, lots of stuff I'm leaving out, I'm sure, but we continuously work with our enrolled patients to ensure that they're getting the specialty care that they need.
Thanks, Rita. I'm going to go ahead and open it up for questions. And if we don't have any questions, I'm happy to keep asking you questions, Rita. But I wanna give folks an opportunity to ask their own questions. If you have a question, feel free to unmute your line. Or if you feel more comfortable just dropping it in the chat box, feel free to do so. Well, until we have more questions, I'm going to go ahead and keep asking you questions, Sarita. What is a good example of
I'm sorry.
Excuse me.
This is Mike. And I'll pitch this to the team that worked on the report, Sarita and JP and others. As you were going through this report and looking at the data and compiling it, especially, whether you were talking about disease prevalence, for instance, or other underlying social and economic conditions, were there any surprises that jumped out at us, especially as it relates to what we found in our last demographic report?
For myself, I think the point that Sarita hit on with this, with Leander, Jonestown, and East Austin really rising to the top with the prevalence of disease. These are areas that are just completely you almost couldn't pick two areas in Travis County that were more different from each other. One is in the urban core, one is in the rural section, northwest section of the county. Yeah. East Austin has our highest total count of Black residents. Leander, Jonestown has the lowest. They have the highest count of white residents. So I think that's a good lesson, and there's a lot of things that can surprise us out there, and so we got to keep doing this work and dig in a little deeper in that information.
Yeah. So the trends, change much faster than what they have in the past, and it's evidenced by the Jonestown findings.
Yeah.
Right. Yeah.
And I will say also, this information, this burden of chronic disease, this is new for us. We're setting baselines with this report for which we'll be able to measure against in the future.
Right.
Right. This is more or less a new approach to look at this at the census tract level. So, but again, it was, as JP said, to elaborate a little bit on that, is that we do need to continue to investigate all areas. We don't limit the scope of where we might want to assume services should be, because we're not looking, when we look at a map, when Central Health looks at a map of our population, that map isn't the general population of Travis County. That map is already restricted to those folks who are impoverished. And poverty, as we know, contributes a lot to disease. And it also may, it means that the population may need more services than just a general population who may have more resources available to them. So,
Right. Thank you. Appreciate the commentary.
Thanks, Mike. Are there any other questions from people who are here joining us? Okay, Sarita, what is a good example of practicing socially conscious medicine to address diseases? So, and what would that look like?
sure. So, we often hear in the clinical setting providers telling patients to, just you need to do more physical activity, get that walk in, go do some 30-minute walk every day after work. But to understand again that what that means to that patient. Are they talking to a patient who is in an unsafe neighborhood that doesn't have sidewalks, or their sidewalks are broken, they don't have well-lit streets at night, and it's in a high crime area? Is it really feasible for them to take that walk? If you're asking someone, you're telling them to make sure that they eat produce and nutritious food, rather than, understanding that there are things there as well. But do they have money to pay for that nutritious food? How have they figured out how to budget for that food? So again, meeting those folks where they are, understanding, and not figuratively understanding why it may be that they can't follow the recommended routines that their providers are telling them they need to do to improve their health.
And Sarita, as a follow-up to that, there's a question in the chat box about once we refer patients to a variety of social condition services, do we track the referrals to see whether the patient got the services and so on?
Our medical management team, as I said, they do follow up with these patients and ensure that they're getting the services that they need, and that they're, if they're going in for the appointments. And yes, the answer is yes.
Awesome. There's a specific question around community health workers, and I know we've mentioned that we're using community health workers at various capacities. From community outreach, we're in the process of hiring community health workers to help with some of the grassroots outreach efforts, and making sure that our MAP members understand their benefits well, and that there's no lapse in coverage, or less lapse in coverage for our MAP members. So that's one way, Ricardo, that we're using our community outreach specialists, community health workers. Also, our medical management team uses community health workers, as Rita has mentioned. The question is, how are community health workers being incorporated in addressing these community needs? And one answer is referrals and connecting the dots for patients. But Sarita and anyone else, if you would like to build on that, please feel free to do so.
Yeah, one example I know during COVID is community health workers at the Southeast Health and Wellness Center has stepped up and created a food delivery program specifically for our patients who were discharged from the hospital and then needed to isolate. So they were working with some other local entities, Cat Metro, Austin Public Health, to make sure those folks had access to food. They were at some of their most vulnerable times. So that's just one example.
Thanks, JP. That's great. Does anybody else have any other questions? I've been following the chat box here. This is a great conversation. All right. Well, if no one else has a question, again, Catalina, did you have a question? Go ahead.
Yes, I did. Thank you so much for this information. This is really great stuff. I'm curious, we were talking a lot about the patients, but Sarifa, you mentioned a lot about from the clinic side. So is there an educational piece that's coming from the clinic on how to ask proper questions and how to really meet the patients where they are?
That is work that is coming down the pike, and we'll probably be hearing more about that at some point. But it is work that we're discussing. And you know, there currently is annual training that we do to ensure that folks are and I know this term has kind of gone by the wayside in the community, but ensure that folks are culturally competent in how they care for our community when they interact with our patients.
Great. Mike. go
Ivan,
ahead.
just to respond to Catalina's question, there are some materials that I've seen both in different languages, and as Sarita mentioned, just training that happens at the clinical level in terms of being culturally affirming. That does speak to, you know, here's what to expect. Here's how to be a patient. But still, and you know, one of the big gaps that we need to look at, and not just look at, but address, even above and beyond what's happening today, because there's a lot of good work out there that does exactly what you're getting at, is that navigation piece of it. And I don't know if you've had the opportunity to tune in to any of our strategic planning committee meetings, but our chief strategy officer, Monica Crowley, she's and her team working with community care as well as healthcare delivery division and others are really honing in on a systems-based approach that has the patient at the center of it, and at the center of that as well, alongside the patient, is this navigation piece. And that's something that, you know, we don't just want to take it for granted and say, well, we've got printed material, we have people that are trained to have these conversations. We always want to keep up in our game, because to the extent that you know, that patient has a much better experience, that person served has a much better experience, because they understand, you know, how this system works for their health, I think is just all the better. So you ask an excellent question, and there's been some good work there, but there's much more that we'll continue to work on and do as part of this systems-based approach and looking through an equity lens.
All right, everyone. Yes, thank you, Mike. And it is past noon. And so at this time, I'd like to just thank everyone for coming. This concludes our series for the demographic report. And we will see you again next year. In the meantime, we hope that you have a very happy but safe holiday season. Please make sure to wear your mask if you go outdoors, gather outside, or open your windows. Keep everything ventilated. Wash your hands constantly. Stay safe, everyone. Again, thank you so much for joining us, and be safe.
Thank
Goodbye.
you, everyone. Thank you, Ivan. Thank you, Sarita.
Thanks, everyone.